In this video lecture, we'll discuss two closely related anxiety disorders, panic disorder and agoraphobia. As you might expect from the name, a defining characteristic of panic disorder is that an individual experiences panic attacks. Panic attacks are included in the DSM as a specifier. The DSM defines the symptoms that define a panic attack, but a panic attack itself is not a mental disorder. Panic attacks can occur in the context of panic disorder. They can also occur in the context of other anxiety disorders, other kinds of disorders, medical conditions, and can also occur when no disorder or condition is present at all. A panic attack is defined as an abrupt surge of intense fear or discomfort that reaches a peak within minutes and is accompanied by 4 or more symptoms. Those symptoms include physiological symptoms like increased heart rate, feeling like your heart is pounding or you're having heart palpitations, sweating, trembling or shaking, and shortness of breath. There are also psychological experiences, including derealization or feeling like things around you aren't real, depersonalization, feeling like you are not in the world or real, as well as a fear of losing control, a fear of going crazy, or a fear of dying. Panic disorder is characterized by recurrent panic attacks, meaning that the person is experiencing more than one. In panic disorder, these panic attacks are also unexpected or uncued. So remember that panic attacks can occur in the context of many different disorders, and individuals without any disorder can also experience a panic attack. You might, for example, see a panic attack in the context of a specific phobia when an individual is exposed to their phobic stimulus. Someone with a fear of spiders might experience a panic attack if faced with a large, surprising spider. An individual with social anxiety disorder might experience a panic attack if they need to give a public presentation or performance. These would not be indicative of panic disorder because we can see panic attacks across our various anxiety disorders. In contrast, panic disorder is diagnosed when an individual is having recurrent panic attacks where they can't identify any specific cue that's leading to these recurrent panic attacks. In addition to experiencing recurrent, uncued panic attacks, at least one of these panic attacks is followed by at least 1 month of one of 2 changes to behavior. The first could be a psychological change. The individual experiences persistent concern or worry about experiencing further panic attacks, or about consequences these panic attacks might have, such as worrying that they will lose control, have a heart attack, or worrying that they're going crazy. As a result of the recurrent unexpected panic attacks, the person is worried about having more panic attacks in the future, or that having these panic attacks means something bad for their physical or their mental health. The other way to meet this criterion is that the individual may experience at least a month of significant maladaptive changes to their behavior related to the panic attacks. For example, someone might change their behavior in order to avoid physical sensations that they're worried will trigger a panic attack. They might avoid engaging in exercise because they're worried that getting out of breath and having a pounding heart will bring on a panic attack. They might avoid watching scary movies that they're worried will lead them to having a panic attack. They might even avoid things like engaging in sex because they might be worried that the physiological consequences could bring on a panic attack. These would all be examples of significant changes in behavior related to the panic attacks. Another anxiety disorder, agoraphobia, is closely related to panic disorder. Agoraphobia is characterized by marked fear or anxiety about at least 2 of the following situations: using public transportation, being in open spaces, being in enclosed spaces, standing in line or being in a crowd, or being outside of the home alone. In agoraphobia, the individual fears or avoids these situations because of concerns that they may not be able to escape, or that they may not be able to access help if they experience a panic attack or other embarrassing symptoms. So this looks very similar to our diagnostic criteria for specific phobias and for social anxiety disorder. We have marked fear or anxiety of a specific situation. In this case, the situation is a set of concerns about situations where the individual might experience a panic attack or other symptoms. And the nature of the fear is that the person is worried that they might not be able to escape or get help if they experience a panic attack or other embarrassing symptoms. One way to think about agoraphobia is that it's anxiety about panic or related anxiety symptoms. The thing that a person is afraid of is that they're going to have a panic attack or another embarrassing experience, and they won't be able to get out or get help. Similar to the criteria for specific phobias and social anxiety disorder, the agoraphobic situations almost always provoke fear or anxiety. The agoraphobic situations are actively avoided, or if they cannot be avoided, the person experiences intense distress. The individual may also require the presence of a companion. For example, someone may be able to endure their agoraphobic situations, but only with a partner or a child with them. As we saw in our other anxiety disorders, the fear or anxiety that the person experiences is disproportionate to the real danger posed by the agoraphobic situations and to the sociocultural context. It's also persistent, typically lasting for longer than 6 months. And finally, the fear, anxiety, or avoidance of the agoraphobic situations causes the person to experience clinically significant distress or impairs their ability to function in some important domain. Panic disorder and agoraphobia are closely related to one another. This figure presents prevalence data from the National Comorbidity Survey replication. More than 1 in 4 individuals reported experiencing a panic attack at some point in their lifetime, and more than 1 in 10 had experienced a panic attack in the past year. Panic attacks are very common, but most people who have experienced a panic attack do not meet criteria for panic disorder. About 1 in 4 of the people who reported a history of panic attacks had also met criteria for panic disorder or a related disorder in their lifetime. About 1 in 5 of people who had a history of panic attacks had met criteria for panic disorder at some point during their lives. About 25% of these individuals also met criteria for comorbid agoraphobia. Most people with a lifetime history of agoraphobia also meet criteria for a diagnosis of panic disorder. However, there are cases in which individuals can meet criteria for agoraphobia without meeting the criteria for panic disorder. Many people with agoraphobia experience this anxiety because they're worried about having a panic attack. But individuals can also develop agoraphobia if they're worried about other consequences. For example, someone with irritable bowel syndrome might develop agoraphobia if they're worried about experiencing gastrointestinal distress in a public situation and not being able to escape or get help. So you might have the same kinds of behaviors and fears that characterize agoraphobia that is typical of panic attacks with other kinds of physical or psychological experiences. But often when we see agoraphobia, we're seeing it in combination with panic disorder. A person experiences recurrent panic attacks, they're worried about the panic attacks and they're changing their behavior, and one specific element of changing their behavior is that they develop a fear of situations where they might experience a panic attack and be unable to escape or get help. In that situation, we would give a diagnosis of both panic disorder and a diagnosis of agoraphobia.